So our next topic is sexual function after SCI. And we have Margeret Conquest, who wears many hats, her favorite being one as a real-time vulnerable co-conspirator with women with disabilities trying to live their best lives. She has 33 years of lived experience as a quadriplegic, has a passion for pushing higher in life, and when it comes to perimenopause and menopause management, there isn't much she hasn't explored. She has a master's of science in health promotion studies, has studied sexual health, and has spent most of her career working in the nonprofit disability sector. Retired, she has returned to her enduring interest in sexual health with a current focus on pleasure and sexual health education for women in midlife. When not connecting with other women, Margaret loves to spend time with her husband and extended family and is an avid gardener, van lifer, baker, and lifelong athlete. We also have Raj Parmar. She is a nurse practitioner working with SCI for the last 17 years. She began her nursing career in Vancouver and moved to Calgary in '99. Once in Calgary, she worked at the Trauma Intensive Care Unit at the Foothills Medical Center until 2007. And while working in ICU, she finished her Master of Nursing through the U of C. After completion of a master's, she moved to the Department of Clinical Neurosciences in the Division of Physical Medicine and Rehab as a clinical nurse specialist, working mainly with SCI population. She went back to school in 2013 to finish her nurse practitioner program. And since then, she has been working with spinal cord injury rehab program as the NP on tertiary neural rehab and outpatient SCI clinic. Her main goal is to bridge any gaps in SCI care in the community. Focus of her practice is bowel, bladder, wound care, and sexual health. In her free time, Raj loves to spend time with her husband, her two young adult children, and she also enjoys running, hot yoga, traveling to new places, and relaxing with a glass of wine. And last but not least, we have Dr. Jen Litzenberger, who completed her medical school and residency training in physical medicine and rehab at the University of Calgary. She has special interest in spinal cord injury rehabilitation, neuromuscular medicine, and general musculoskeletal medicine.
Sex versus sexuality. So we're just gonna, we all know what sex is. So sexuality is a little bit broader than sex. Sexuality, it involves complex interaction between our physical, psychosocial, cultural, emotional, and spiritual dimensions. It includes all our feelings, attitudes, and behaviors that contribute to a person's own sense of being. We all know that our sexuality has two sides. Like we have a public side and we have a private side. Public is who we are outside in the public, and private side is our deeper feelings about affection, attraction, sexual interest, sexual values, how we physically express our sexuality either alone or with a partner. And I'm still trying to see if I can get my slides open. Okay, got it. So the sexuality will represent the comprehensive nature of sexuality. Our sexuality is influenced by, many variables, including like our families, our peers, the culture, the law, media. All these things influence our sexuality. This is an updated sexuality wheel now, and we can just see the people with a disability. Their sexuality is impacted by changes in their physiology, body image, and self-esteem. There was a study done long ago. The study was done with able-bodied people, reporting that when we go for an interview, we're judged based on our looks and how we look rather than our credentials and our personality. That study was done on able-bodied people. You could, for obvious reasons, disabled people are concerned about their appearance and body image. And there's a lot of, after the spinal cord damage, there's uh, there's a changes in their roles, and there's some misinformation and sexual implication of disease and disability. There's misconceptions and unrealistic goals for sexual performances after. And the last three we could work on as a healthcare providers. We can work on those things and try to give our patients some education and try to get rid of some of the misinformation and misconceptions. Next slide. We all know sex is important. It's a bodily function. And then if it is that important, then why are we not talking about it? There was I'm using the same slide as Dr. Charbonneau and their group used. The same study found when a study was done, and it found that the quadriplegic patients want sex. Dr. Litzenberger, can you go back to this old slide? Sexual health was number 2 after the hand function. People wanted more information around sexual health. And for paraplegic, it was number 1. They wanted to have more information around sexual health. So if our patient wanted to know about the sexuality and wants some information, and why are we not doing a great job in that regard? I think we all know our limitations. Sometimes it's the education. None of us have had any education on sexual health. And so it's anyone working in sexual health area knows that this is your special interest. You find this information and you learn and try to provide that information for our patients. So this would be your chance to learn around sexual health, the changes that happen after spinal cord injury, and how to approach these sensitive topic of sexuality with our patients. Next slide. That's Dr. Litzenberger.
Yeah. So I'll jump in and talk a little bit about the anatomy. And I think when we do so, it helps make things just make a little bit more sense in terms of what symptoms a person might be experiencing or what functional changes a person might then have to now live with. So from an anatomy standpoint, with erection, it's sometimes the most simple example. And so that's where I'm going to start. This is an already simplified version of the anatomy, but let's pull it back a little bit more and make it even more simple. So at the top, we have the brain. And of course, the brain sends the nerve signals down to the body through the spinal cord and then the peripheral nervous system. The peripheral nervous system then sends signals back up to the spinal cord and then back up to the brain. When we're talking about sexual function, and again, starting with erection, but understanding that from there's differences in anatomy, but this is the best sort of easy way to understand it. Some key areas are the thoracolumbar erection center, which is at T11 through L2. So at the lower portion of the thoracic spine and the upper portion of the lumbar spine. Understanding again that the spinal cord tends to end around L1 or at L2. That's where the conus medullaris is. And then from that point forward, there's nerves that are coming down as the cauda equina. And so there is an anatomic distinction from that level. And then the second kind of important area is the sacral erection center. So these are the nerves that are S2, 3, and 4, which affect the pelvic floor, and then also our genitalia. And so you may remember the S2, 3, 4 also important for bowel and bladder function, and then similarly for sexual function. So with normal anatomy, there's psychogenic stimulation, which is where we think about erotic thoughts, things that make us feel aroused, can contribute to erection, or again, for women, tissue engorgement. And so similarly, there's the reflexogenic stimulation. So this is with touch. Again, touch can lead to tissue engorgement, whether it's erection or in the vagina and the clitoris. With touch, then that has a feedback loop that causes more engorgement, more lubrication, and again, more erection. And similarly, that then contributes to having some more sexual thoughts. And so there's this feedback loop that for both combine to create that sexual experience. when we have an injury to the spinal cord or to the nerves, and again, this is for purposes of explaining the anatomy, we're going to assume a complete transection, so a full complete injury where there's no incompleteness, because when nerves are getting through, then potentially that changes things. So if there was a complete injury above the thoracolumbar erection center, so above T11, maybe in the thoracic spine or the cervical spine, the signal from the brain down, so that psychogenic stimulation where we have the erotic thoughts, gets blocked. What we do still have, though, is the reflexogenic stimulation. And so where you might notice is with touch, or you can get an erection or tissue engorgement. And sometimes this is in a sexual setting, but sometimes it's not. And so this is where we can get that reflex erection when trying to do the bladder routine or catheterizing. And so understanding that this is actually a normal anatomic situation hopefully takes away some of the stress that can be associated when that happens in an unwanted situation. Similarly, if there was an injury to the sacral erection center or the lower motor neuron, the cauda equina injury, that can block that reflexogenic stimulation or that reflex erection. There is still a pathway that can get through where we have the psychogenic stimulation, or sexual thoughts still can contribute to an erection. And so it's not zero in terms of the chances that the tissues get engorged or that there's lubrication, but it is a little bit less. And so hopefully demonstrated through these examples, we can see that there's possibility from two different pathways to be able to achieve tissue engorgement, which results in erection or excitement, and lubrication. So to break down just some numbers again, because even with a complete lower motor neuron injury or an injury to the nerves that supply our genitals, there's still 1 in 4 that can achieve tissue engorgement or erection. Now, this table is with aids to improve tumescence. So we're going to talk about those later, but things like injection, things like Viagra, things like vibration device. This is with all the best tools that we have in our toolbox. A complete upper motor neuron injury, so the upper thoracic spine or cervical spine, has really good opportunities in 95%. Incomplete also has really good opportunities, again, because some of those nerve signals are still getting through. But even with a complete lower motor neuron injury, there's still some chance, but as you can see, it's a little bit harder. So an interesting distinction that we're often making in clinic is for males in particular, ejaculation and orgasm are often tied together as the same experience. From a nerve standpoint and a physiology standpoint, they're actually very separate processes. And so after spinal cord injury, where there is now an interruption to those pathways, they're now separated. And so a person could experience ejaculation without orgasm and vice versa. And it can take some getting used to in terms of that unexpectedness of what's now happening. Ejaculation is often impaired in spinal cord injury because it is such a delicate neurologic system where there's sympathetic, parasympathetic, and somatic nerve connections that have to be intact and firing at the right time in order for an ejaculate to move forward or anterograde. And so 1 in 5 would retain the ability to have some ejaculation. This can be increased with assistive technologies, and there are options for when we're trying to ejaculate for fertility, but just from a regular ejaculation standpoint, that does become a little bit more challenging. From an orgasm standpoint, now this is actually experienced in the brain, not technically in the genitals. And so it's a cortical experience that happens in the limbic system of the brain. Having cold sensation and voluntary anal contraction on that digital rectal exam indicates that there are intact neurologic pathways for what we understand to be orgasm. But the brain can work independently from the injury. And so even if there was no cold sensation, no voluntary anal contraction, and no sensation whatsoever of the genital area, the brain can develop a new body map where using neuroplasticity, you can create this new erogenous zone. And so the parallel that I can maybe draw from is where, ears or nipples can become quite erogenous. And so this does take dedication and commitment and working together with your own body and perhaps with a partner. It doesn't just happen on its own. It tends to happen through training, but it is something that can be tapped into.
And if I can add an example of that from myself, it's the biggest secret that's not a secret, because I tell everybody about this. So my level of injury is C6, C7, and the inside of my elbow is a very sensitive spot and an erotic spot. And so the big, like sexy, crazy thing that we do in public is my husband will come up from behind and touch the inside of my elbow. And it's known between the two of us as a sexy touch. And even when we watch TV together, not having trained that neural pathway, it can be a real great core play, foreplay, all of it. So
excellent.
Just an example.
Thank you. So again, from an orgasm standpoint, the statistics would say that women are a little better off than their male counterparts in terms of being able to experience orgasm after spinal cord injury. And still that incomplete injury is a little bit higher opportunity just from a statistical standpoint, but each person's an individual, and so each injury is different. Oh, so this one was talking about the new erogenous zone, which often is an area that's above the level of injury or at level of injury that can create that feeling. So to continue with anatomy, moving into the female anatomy. So similar to the males in terms of excitement and arousal, there's the reflexogenic region for stimulation and the psychogenic region. Lubrication requires an intact innervation and estrogen levels. And so complete lesions at T10 through 12 might interfere with that lubrication. And so then we talk about just using an exogenous lubricant. Typically we'll recommend water soluble as opposed to oil, because oil is a good nidus for bacteria. And so water soluble would be preferred. And then there's this thing called accommodation. And so the pelvic floor typically during arousal will rise in female anatomy. And so without that rising of the pelvic floor, sometimes there can be a feeling of impact, which can be there with penetration. Again, that's part of the injury and it's nothing to be alarmed about.
Can we just go back really quickly to talk about the lubrication, the added lube choices? Now, I noticed that you didn't mention silicone as a lube to use. And I know that water soluble, depending on the osmolality or the amount of water it can draw out of or into tissues, can be more irritating to vaginal skin for women. And so sometimes silicone is better. It lasts longer, and it has less chance of causing irritation. And so that's a third one that I think is important to mention. And then whatever your choice of lube is, to look at the pH of it to ensure that the vaginal microbiome is still intact.
Excellent. Thank you. This is great.
Is that, sorry, I'm like,
this is very helpful.
That is like very weird, or
no,
awesome?
Not at all. Appreciate it. Please keep jumping in.
Okay, excellent.
So from a fertility standpoint, from a female perspective, there's technically no impact from the spinal cord injury, but there is a caveat to that. And so a big caveat is the spinal shock that can happen afterwards. And so typically menses will resume 2 to 8 months after injury. But knowing that, it's important to consider that period of time where, the egg does drop before menses will resume. And so using contraception if pregnancy is something that is not desired. So from a contraception standpoint, there's many considerations that are out there, many choices that are out there. And for each person, there's going to be things that are preferred just from a personal and life standpoint. But then there's also some considerations. And so for just some examples, the oral birth control pill has a slightly increased risk of DVT. And so if you were predisposed to having blood clots, that could be a consideration. Progesterone-based contraceptives can impact bone density in a negative way. So again, maybe a consideration for contraception. Contraception such as IUD or anything that has a physical component, the sensation or the chance that it could erode through tissues. Again, none of these are contraindications. They're just considerations. And so making sure that you're able to make the choice that's right for you, and then knowing what potential side effects or risks that might be associated with them, so that if something does happen, for example, if you have an IUD and then you have autonomic dysreflexia that's not going away, remembering to check that the IUD hasn't migrated as a cause for those symptoms. Similarly, from a pregnancy standpoint after spinal cord injury, again, it's more about planning and some considerations. So, for example, some of the medications that a person might be on, like gabapentin, aren't necessarily recommended or ideal during pregnancy. Managing bowel and bladder as the mobility changes as the pregnancy progresses can also be impacted. Plus, you always hear pregnant people talking about how they have a tiny bladder, which might mean having to catheterize more often, again, because there is something that's now sitting there. The skin, because the pressure map will change as your body distribution changes as becoming pregnant. The DVT risk, which again is consideration. Perhaps if respiratory weakness is already considered, how having a pregnancy could impact your respiration, autonomic dysreflexia. And then breastfeeding. Typically with breastfeeding, there's that feedback loop that happens from sensation at T4. And so if that's impacted, it's not that you wouldn't be able to breastfeed, but maybe having to then have extra assistance or medications to promote lactation, because that natural feedback might be interrupted. For the time of labor and delivery, again, autonomic dysreflexia. Preeclampsia is a condition where the blood pressure in the mother increases before delivery, which can actually turn into eclampsia, which is a seizure thing that happens right before, and so it can be quite dangerous. So blood pressure might be increasing because of autonomic dysreflexia versus preeclampsia. So again, it's just all of these things are highlighting that it's important to involve the obstetrician in somebody that is knowledgeable about spinal cord injury. From a mobility and accessibility standpoint, things might change, and so being able to plan for that. And recognizing that postpartum depression is more common in people with spinal cord injury, and so really being there and screening for patients or for each other if it's peers, so that we can make sure that we're not leaving people out that require increased screening and maybe assistance. So understanding that there are many, many options that are available, but none of them are perfect. And so this is where it sometimes feels like trial and error. There's always something that can be, I say done, but I mean tried, because really there's things that can be tried. There's not always something that can be done. And so I love this framework that was created by the group in British Columbia that kind of outlines the different pieces to sexual rehabilitation. Things like the sexual drive and interest, which we're talking about, function, contraception, and fertility, considering medical consequences, how bowel and bladder issues can impact things, same with motor and sensory influences, and self-view and partnership, which is so important and often, even in this list, left to the end, even though it's so important and can be brought forward. And so giving a few examples, so for sexual function, from an erection standpoint, this is where, medicine has so many ways to work around it, and the female anatomy is often left to the side without much to offer. But oral medication, so you've probably heard about things like Viagra, Cialis, Levitra. There's injections that can be done directly into the penis that can also be of benefit from an erection standpoint. Vacuum erection device with a pressure safety valve. Because of the impaired sensation, there is a risk to the vasculature of the penis if the pressure safety valve isn't there. And so unfortunately, that does mean having a slightly more expensive device, but please no over-the-counter non-safety valve devices. And then even implants if needed. And so there are lots of potential options that are out there. From a medical consequences standpoint, we talk about things that are associated with spinal cord injury, so pain, fatigue, spasticity, autonomic dysfunction. These all can get in the way of your sexual experience, and so being able to manage those is part of the conversation when we're talking about sexual health. Other conditions that a person might have that are adding to challenges with sexual health. From a medical standpoint, I talk about things like testosterone. So we know in spinal cord injury that there is often an association with decrease in testosterone, which can impact erectile function and sexual drive. The challenge here is that if you give exogenous testosterone, or you take testosterone, it impacts spermatogenesis, so your ability to make sperm. It is felt that if you stop taking exogenous testosterone, that can improve. But with spinal cord injury, unfortunately, there is also a decrease in fertility from the sperm health standpoint that starts fairly quickly. And so we often say, you know what, if you're thinking about wanting to procreate, maybe hold off on taking exogenous testosterone until the fertility and that piece is decided, because it can impact it and in a detrimental way. We again talk about bowel and bladder and sex and how to go about it. So there's a big myth about the Foley catheter that you wouldn't be able to have sex. And it's true in that this is part of the reason why we often try transition to a suprapubic if we're going to have an indwelling catheter. But you can. The catheter can be pulled and taped and covered with a condom or held back against the abdomen. So it is possible. It's just, again, if there's another option, then that's what we will also try brainstorm. Things like a bowel routine and bowel routine timing can be considered, because in hospital, again, we often move bowel routine to the evenings. Well, is that the most ideal time? Maybe, because then maybe you have a bowel routine and everything's done, or maybe you transition to a morning routine, so it's not something that you have to worry about. And then the other piece is just planning. So unfortunately, in the setting of spinal cord injury, sometimes some of that spontaneity is taken away because you do have to use medications or think about positioning or do other things like bowel routine or bladder routine. And so it does take a little bit of extra effort. And so that's something that I think we empathize with.
You know what? I've always challenged this though. I don't think that other than in Hollywood movies, sex for anyone is spontaneous. If you're going to go to the bar on Friday night and you're looking at what you're going to put on, and you're going to put on some makeup,
True.
and you're thinking about getting laid, you're planning sex. You're actively not planning sex also when you don't want to have sex. So I often try to couch things in those terms that, yes, we're grieving some of the spontaneity that we used to count on, or sort of the sequence of events, but it's also not exclusive to you having had a spinal cord injury. That spontaneity is gone and never going to come back.
I love that. That's good.
And there's some sexiness in planning. So
I love this. Thanks, Margaret. So from different devices that can be used, there's this great manual that was put out by the Disabilities Health Research Network in BC. Just for me, what it's helpful for is it just gives ideas. And so talking with your local OT, brainstorming, talking with peers to come up with different ideas of what might be helpful for you. But just as examples, so there's different shapes that can help for positioning. There's slings that can be used. There's bouncers that can be used, and nothing's perfect. But I think there's products that are out there, and again, it takes a little bit of creativity. And then the sexual self-view and partnership, which Margaret is so wonderfully going to also add even more than you already have. And so I'm very looking forward to this. And so next step, Raj, are you back?
Yeah. Can you hear me?
Yes.
Okay. So I think next step is, now you got this knowledge. How do we start the conversation? I think the main thing is just meeting the patient where they are. Like if they bring up any topic around sexuality, if you don't feel comfortable talking about it, just letting them know, okay, we do have these services. I don't feel comfortable talking about it, but I can connect you with someone else who could. Just not leaving patient open and making them feel vulnerable that they asked this information and we're not giving that information. Even just saying, this is really good question. Could I get back to you? Could I connect you with a person who could have this conversation with you? Next slide. So I think we use a implicit model when we talk about the around how to bring up the topic of sexuality, just asking permission. I think start with asking permission from the patient, or patient gives you permission to talk about it. Then even give limited information. You don't have to go into in-depth. Just give them some limited information and connect them to our clinic. And just working on your education. I think that's the big thing. I'm going to try to go through the slides quick. I think we need to give some time for the questions, and Margaret some time as well. Glenrose does have a sexual health services. Their services looks really interdisciplinary. They do have a nursing, OT, psychology, and social work all involved in their clinic, and they could do the urology referrals for rectal dysfunction, and they do have a gynae clinic as well. That is amazing. And the patient could self-refer them, or the referral could be submitted through their services. And for us here at Foothills, it's a two-women show. It's Dr. Litzenberger and myself. We don't have huge other support, like except our management and everyone else who's supposed to run our clinic. So most of the times I will see the patients up on the unit as inpatient and then try to book them into our clinic. The first meeting, most of the times I give them just general information and give them the resources that we will be sharing with you guys. And our clinic is a patient could self-refer, or anyone from the community could refer those patients to us. And we're very specific to spinal cord injury at this time, because it is just two of us and we just know spinal cord injury. And so is there a role for other people to come join us? Of course, we could use someone who could counsel, do some counseling, social work or psychologist. We could have, occupational therapist that could help us with the equipment, or, any of those things, and braces, whatever those other things we need. From nursing to have more help around bowel bladder, and physiotherapist. Everyone has a role in this, and we would encourage people to come talk to us if you are interested. Next slide. I'm just going to share some of the resources. This is the resource I always give it to our patients. It's a spinal cord injury from British Columbia. If at the minimum, if patient asks, bring up the topic of sexuality, give them this, SCI sexualhealth.ca. It literally goes through every single thing. If they are thinking about it, BC, British Columbia, they thought about it, and it is written up. And so as a healthcare professionals, if you want it more in depth, go to SCAR project and look up that information. You'll have plenty of information in there. And so those are all the informations that you could just start the topic. If you don't feel comfortable, if the patient brings up the topic, give them the resources and send me a message, and I'll go see the patient at that time. And
let's
Margaret,
let Margaret talk. Yeah, let's let her talk.
Yes, Margaret.
So I'm going to sort of go back a little bit. You don't have to go back in the slides because we don't need that kind of back and forth. So, I have a spinal cord injury at the C6-C7 level. I've had in my injury for 33 years, and I've experienced lots of things, and I've also experienced some inertia. And it's not just because no one cares. It's because this is just such a multifaceted topic. But unfortunately, I feel like we're still discussing the same things in the same ways sometimes that we did 33 years ago when I was first injured. So again, and there was one question that was asked early on in the chat about what things are being missed during an inpatient stay at the hospital. And I don't know that it's always getting missed, but we talked about very early on in the presentation, starting where people at in the context they come to you, and the external messages they're getting. And in addition to that, I would also like to put in the lens that people with spinal cord injuries are also comparing themselves to who they were and how they functioned and interacted prior to their injury. So there's all of these other external messages that always were there and their history, but there's also this mirroring where they don't recognize who they see in the mirror, and they don't know yet. They don't have a history of themselves yet to look back upon to build their new self-image on. And I think that that's an important thing to encourage newly injured people about, and that image that they can build it and that they can reinvent themselves. Who they were and what their story was is not who they necessarily need to be going forward. So I think that's a big thing that maybe doesn't always get addressed in rehab. There's some discussion of communication and planning, and I already talked about this a little bit earlier. I think that letting individuals with spinal cord injury know that it's a myth that sexual encounters are spontaneous, and that there's this loss that you can never get back after injury. And then I also think that, so when I was injured, I was 16, and I came to my life post-injury as having a very little sexual self-concept, and what little I had was really genitally focused. It was focused on a heteronormative idea that the right sex is sex that involves a penis and a vagina or some sort of penetrative activity. And you don't necessarily want to say that genitals are second rate, but I think that it's important to look at what activities are going to be likely to bring the highest chance for a peak experience, whether you're a man or a woman. And there we can tap into very basic knowledge about arousal around oxygenated blood, about being having low stressors or taking away some of the stressors, like the garbage. Garbage can be a great foreplay. Get that shit out of the way so that you can focus on what is sexy. If you're worried about your bowel routine, and this is again when people are like, well, I don't want to plan my bowel, I don't want to plan sex or after my bowel routine. Well, if you shit your pants on a regular basis, maybe plan sex for after that. So you don't have that. There's this thing called spectatoring, where while you're in an activity, a sexual activity, an intimate activity with somebody, you're over here looking down and thinking about, am I going to pee my pants? How do I look? How do I feel? Is my gut hanging out very much? Do my boobs hang into my armpits when I'm laying on my back? And all of that stuff. And if you can take care of yourself in that, giving yourself time to become aroused and to become tuned into your partner or yourself, some of that can go away, at least, or it can be muted. And I think it's important to encourage in men and women that are coming to you with who have a spinal cord injury, because I think it's still incredibly pervasive that we are focused on how to get to an orgasm very quickly and how to do it the way that we've seen it in porn. And the way that we've been taught is the way to get there. And so it just is I don't see that as being something that is impressed upon people still today. And I also understand there's so much information that you're trying to impart in a short amount of time, and also in sometimes awkward encounters. The mix of people that are in group education sessions can be really weird. I also am not a fan, actually, of co-ed sexual health education sessions. I think for women specifically, and anybody who's had any sort of trauma history, that's a very daunting place to try to come and gain new knowledge or to change the way that you approach something and your attitudes if you have some history with trauma with either the opposite gender or anyway. So I think that that's something that's missing in rehab. What else? I'm trying to be a little bit quick so we can still allow for some more questions. If you've ever seen me do any of my sessions around pleasure, I like to focus on eroticism and the idea that eroticism and sex are not the same things. that sex is one component of eroticism, and that learning how to tap into your erotic self throughout your whole day. And by tapping into your erotic self, I mean tapping into the things that make you feel alive and give you meaning, that can go a really long ways to helping you tap into your sexual self with someone else or with yourself. And that also speaks to the dual model of desire. Desire, regardless of what your physical sexual function is like, your arousal, your ability to impact your desire, understanding that there's a gas pedal that you hit and there's also a brake pedal that you hit, and that during rehab or during stressful times, that it's absolutely real and believable that you have zero desire for sex if someone's really, really pressing on that brake pedal, and that no amount of pressing the gas is going to help you if you can't see both of those controls. And then, one other thing that I wanted to bring up that wasn't included, and this is because I've got a teeny tiny platform right now, is that the entire lifespan of women was not included in the earlier slides. And no one talked about menopause. And it's not every woman will experience pregnancy or childbirth, but absolutely every woman who's lucky enough will experience menopause. And there are some really consequential things to consider when it comes to a woman who has entered, is in perimenopause or is postmenopausal, because there's considerations around bone loss, genitourinary syndrome of menopause, and then symptom management options and how those are impacted by your status as a person with a spinal cord injury as well. And then, yeah, so that's like a quick and dirty version for me to speak about things from a lived experience, as well as the people I've encountered as a sexual health educator and a peer over a long time. So I may sound like I'm rambling, but I'm hoping that I've been able to give some information that is useful for folks.
Thank you, Margaret. You actually covered most of the questions that were in the chat box, so that's awesome.
Oh.
Yeah, that was great. We're actually just past the question period, and I just need to keep things a little bit on track just for the next presentation. But that was phenomenal, you guys. I wish you had had more time because every one of you was super interesting. Thank you.
Thank you.
Everybody.